think in this paper you set out to compare the people in a particular special needs plans, a company by the name of CareMore, roughly 450 of people in the CareMore plan to roughly 40,000 people in a fee-for-service Medicare, all of them with end-stage renal disease. And you set out to compare those two groups, correct?
That's correct. I mean, to date, it's been very challenging to make these comparisons in a way that feels rigorous and sort of credible in some sense. And so as we take a step back, either from a policy perspective or a research perspective, it's been a notable gap thus far in what we understand, which is how do special needs plans actually deliver care and how do they perform in terms of cost, quality, and outcomes for Medicare beneficiaries who elect to enroll in them versus the lion's share of Medicare beneficiaries, for example, with ESRD, who get coverage through the traditional Medicare fee-for-service program.
So this study was, the reason why you wanted to do this study is to see whether, from a policy perspective, we're getting anything out of these special needs plans, correct? I mean, if they're not delivering better, more coordinated care as measured by outcomes and I guess utilization, what's the point, right?
Yeah, I think, oftentimes Medicare Advantage as a broad set is considered, privatized or the private plan choice within Medicare. And, has existed for now over 3 decades and is getting increasingly popular, interestingly enough. So Medicare Advantage itself is only expanding over time. And Medicare Advantage plans, as you noted, are capitated, meaning they get a fixed budget for each Medicare beneficiary who elects to enroll in them. And then they're at risk, subsequently, financial risk, for both quality and the cost outcomes. And so it's a version of accountable care, if you will, that's different than the alternative, which is the traditional fee-for-service system, which is great in some sense because it provides great coverage. Almost every physician and hospital out there takes Medicare, so it gives people a lot of choice from the perspective of where I want to go. But oftentimes there's a lot less coordination of care and coordination of benefits. And so to the extent that Medicare Advantage plans are particularly taking care of vulnerable populations, such as those with end-stage renal disease, we really wanted to explore, so are there benefits here? Is it really worth it? Are the benefits and the choice, for example, the flexibilities that Medicare Advantage plans do have, are they yielding benefits for the beneficiaries who are choosing to enroll in them?
So I think you looked at the period of 2010 versus 2013, and I believe that you made two sorts of comparisons: mortality, mortality is an issue in this population. These people their health is not great, and I believe that they, to be blunt about it, they die at a higher rate than the population at large. And you also looked at utilization, inpatient days, things like that. And what did you find?
So I think the most striking finding was that survival was actually higher for the cohort of end-stage renal disease patients who were in the CareMore special needs plan than in a matched group of beneficiaries who are in traditional Medicare fee-for-service. And while no study is certainly perfect, I think one of the reasons we were excited about this study in particular is we were able to use nationally available data that is collected by the government, in fact, on all end-stage renal disease patients, and that data has clinical elements to it. So it's actually fairly granular. We know, for example, for all end-stage renal disease patients, when they qualified as end-stage renal disease, when they were diagnosed, what their etiology or what the reason that they have end-stage renal disease. Is it because of uncontrolled high blood pressure? Is it because of diabetes? Is it for some other reason? We know whether they got a transplant or didn't get a transplant. Actually know what their level of albumin lab, for example, what albumin lab value at the time of diagnosis was. So that level of granularity of clinical information allowed us to find clinically similar patients who were in the SNP and who were in traditional Medicare fee-for-service, and allowed us to make a more rigorous and more valid comparison over time of how those individuals did than perhaps would have been otherwise possible if we were looking at a cohort where we only had claims data, insurance claims data, for example, to do these matching comparisons.
So if I'm understanding you correctly, it was the granularity of the uh, of the database on people with end-stage renal disease that allowed you to do sort of the matching with the CareMore group that enabled sort of a more of an apples to apples comparison on clinical issues that you wouldn't have been able to do without based on claims data. That it was that richness of, and I believe the database is the United States
Renal disease, yeah, it's USRDS. That's right.
Yeah.
United States Renal Data Service, I think. Something
Yeah.
to that effect.
Yeah. Yeah. So in some sense, this paper has, it's interesting, but it's a triumph of methods in some sense, right? Because you have it allowed you to make a comparison that you can't make with many patients because you have all the government collects all this data on kidney failure patients, correct?
That's correct. So we were able to make these credible comparisons that probably wouldn't have been possible otherwise. And I think that's why, folks, I think, should take notice of the results that we have, which is that this cohort of patients actually, they live longer. They actually do better. Their survival is better, or in other words, their mortality is lower if they're in the special needs plan. And to your point, the other outcomes that we looked at, they actually had, better dialysis adherence, it seems. They actually had more dialysis sessions. They had pretty starkly less hospitalizations. So acute hospitalization was lower in the special needs plan group compared to traditional Medicare fee-for-service. And I think that's meaningful. That means people were at home longer, they were getting dialysis more frequently, and probably most importantly, they were living longer.
So, and I think the mortality stat is a hazard ratio stat, and it's 50% was the 51% was the figure. Is that right? In something like that. So that's
correct.
So can we say mortality was cut? It was half as much in the CareMore group as in the fee-for-service group, or is that?
So it sort of builds over time, but I think when we say the hazard ratio, in some sense, what we're saying is the instantaneous, any given moment over this time period, the chance of dying was about half for the special needs plan cohort relative to the fee-for-service cohort. That's how we would describe it in sort of precise methodological terms, if you will.
Right. So why is this paper important? Why should we take heed of this? Is it in fact a bit of an endorsement in the trend towards higher enrollment in Medicare Advantage plans? Roughly a third of people in Medicare are now in Medicare Advantage plans. Does this suggest that we might be getting better health out of that sort of payment system and so on?
Yeah, I think it's a great question. I think, there's, in my mind, two really critical points to make here. I think, number one, this was an area we had very little information or data on to date, right? We knew very little. In general, we tend to know less, for example, about Medicare Advantage performance, quality, outcomes than we do know about Medicare fee-for-service, because as private plans, access to their data is therefore constrained. whereas access to data from the Medicare fee-for-service program is open. So a lot of researchers like myself are able to access that data, and we can study it quite carefully. So understanding MA versus fee-for-service in the first place is challenging. If you take it one step further, which is, what about these populations who are particularly challenging and complex from either clinical and or social reasons, like those with end-stage renal disease, then that kind of amps up, one, the lack of evidence, because we just don't have that much data, but secondly, the importance of that evidence. I mean, these are patients who, to your point, have a baseline high mortality rate. They're very expensive to the Medicare program too. So, on average, they have a disproportionate impact on our tax dollars that go to support socialized Medicare, socialized healthcare through the Medicare system. And so, as policymakers, as taxpayers, as stakeholders in the industry, we should take note of a very expensive, vulnerable population and how they're doing in different types of programs that are being offered, especially ones where we have little information to date. And so finding out here that not only are patients having less acute events, which means they're more than likely saving money for the program and in an aggregate sense, and they're actually living longer, those are two really important data points for us to take note of as stakeholders and policymakers and just citizens, if you will, who are supporting the Medicare program.
Now let's just talk about limitations, because every study has limitations. One, you, as you state in the Health Affairs paper, you weren't able to get cost figures. There are no dollar signs in your Health Affairs paper, which is sort of unusual for Health Affairs. So that's a bit of a black hole, whether there were any savings here, correct?
That's right. I think, so absolutely you're right. We did not, unfortunately, we were unable to get cost data in a way that we could make apples to apples comparisons. And so you're right. So we don't have absolute cost figures. Just on one hand, I would say we do know that acute hospital utilization went down, which tends to be the most costly part of care for these patients as well. So I think that's suggestive. We do know that other parts like end-stage renal, hemodialysis rates went up, and those cost money too. So it's not to say that the cost, there weren't some cost offsets. That being said, remember here for a second that the cost benefits that we would see under the Medicare Advantage program as a special needs plan, those cost advantages are truly accruing to the Medicare Advantage plan. The federal government is already paying a fixed amount to the special needs plan to care for these beneficiaries. So while in the long run, we would think that the federal government would be able to recoup some of those efficiencies, at least in this study period, there was no cost impact, if you will, on the federal government as part of this. I think that was one of the reasons that we felt a little bit more comfortable publishing a paper like this in Health Affairs without those sought after cost figures that you're referencing.